Okay. Okay, good afternoon, everyone. Thank you for joining us today for Breakout Session 3, Navigating the Path of Designing Dementia-Friendly Community Services that Facilitate Independence for People with Dementia-Related Conditions while Aging in Place. My name is Hannah, and I'll be your host for this session. Today, we are privileged to have Ms. Elena Ionescu as our guest speaker. Ionescu will be sharing her knowledge and expertise with us on navigating the path of designing dementia-friendly community services. Before we begin, I'd like to remind you that we value your feedback. This session is eligible for continuing education credit, and today's speaker has nothing to disclose. If you'd like to receive credit for attending, please stay until the end of the session and complete the evaluation for this session contained in the email you received this morning with the subject line OAC 2023 Post-Session Evaluation link. We encourage you to actively participate in this session by putting questions and thoughts in the chat. We will revisit those at the end of the presentation. We believe the information presented today will be valuable and informative for all of us. Thank you again for joining us, and I hope you enjoyed the session. I'll now hand the baton over to our guest, Elena Ionescu.
Thank you so much, Ms. Hannah, for this wonderful presentation. And let me tell everybody how thrilled I am for being here. Let me share my screen, and I'm going to tell you more about the work that I've been doing, not by myself, but obviously it's a team work. Okay, so a little bit about myself. I'm joining today from California, Ventura County, and I'm going to give you a little bit of a geographical lesson within the presentation. I am not yet a doctor, a PhD, but I'm working toward that, and hopefully, finger crossed, I'm going to be awarded this year. But I've been teaching in the gerontology program at California State University for the past 8 years. And I've been in my PhD program for, I'm going to start my 4th year. Okay, and I started working with Ventura County Area Agency on Aging last year, and I'm going to tell you my involvement with this project because this is something that has been going on for a while. Okay, so I hope through this presentation we will identify some steps that will help you create or start thinking about how your community can become a sustainable dementia-friendly community. We will synthesize the needs for aging in place in a dementia-capable community or dementia-friendly community. And we will also look at some factors within the dementia-friendly community wannabe in order to increase the numbers of people accessing home and community-based services subsystem. Okay. So what are we going to do today? About 40 minutes, I'm going to talk, but I'm not going to be the sage on the stage virtual professor. I will like to have you all put your questions in the chat. Again, as I was talking to Hannah earlier, this is such a weird platform for me. I cannot see any of you when I'm sharing my screen. So in order to see the chat, probably I will have to stop the sharing and then come back, and it's just a little bit of mess. So we will keep everything for our Q&A session. I want to say that I know it all, but obviously I will be a total hypocrite saying so. And I am welcoming any feedback, any ideas. This was a pilot project, and obviously I don't think they did it the best possible. There are lessons that we've learned, and hopefully you can pinpoint something that I may have missed within my analysis. Okay, so the facts. By now, everybody knows the reality of dementia being a silent epidemic, not only within California or America, but everywhere. So I'm not going to focus much on this because of our time, but usually we know that by now everybody has been affected by dementia in a little bit or a little bit more capacity. My involvement with gerontology or dementia started because of my father. He passed away due to Parkinson disease dementias, and that was 9 years ago when I was in my first grad school. And then I realized the system, family dynamic system shifting, with my mom being primary caregiver, informal caregiver, and then me being a caregiver at distance, and everything that my mom is back in Romania. I'm Romanian. So in Romania, we do not have yet much understanding from the legislation and policy component of creating community awareness or community education for people who are facing dementia. So this topic for me is absolutely close to home. Yeah. Okay, but we will focus about a little bit on California and why Ventura County was important to look into the concept of dementia-friendly community. So in California, in 2021, where 650,000 people identified living with ADRD, Alzheimer's disease, and related dementia. And this will expect to increase in California alone. So we will have about 840,000 in 2 years. I think these numbers are going to be changed given the COVID numbers shifting with older adults. But it's still a very high number, and we still are paying a lot into dementia caregiving based on Medicaid expenses. So that is a little bit of a concern, because we know we can do it better. With Ventura County, although it's not the largest county in California, we do have a majority, we have a lot of older adults residents, and as you can see, it's expected to increase by 2060 by 139%, 91, like 140% approximately. The income average, and we talk about Southern California, everything is super expensive. A shack, it's $1 million, for having a home. So we know from literature that poverty is very much related to an increase of dementia symptoms. We also know that minorities have also an increase in dementia symptoms. And when we look at the demographics of Southern California, Ventura County, we see that we have a very high population of Hispanic Latino community. So we are, and I think what's also very much important to be noticed is the fact that we have a declining birth rate. A lot of younger adults are migrating, are going to different counties that are a little bit more hip and have a higher chances for jobs into whatever field they want to. So because we have these factors, that will give us even more fewer caregivers to an already increasing older adult population. So it's important for us to understand in more depth the needs of Hispanic informal caregivers for those people living with dementia. Okay, so the little geographic lesson. Ventura County is right here. Here we'll have Los Angeles and Santa Barbara, Orange County and San Diego. This will be Arizona, Nevada, and Oregon. So Ventura County, as I said, is not the first largest county in California, but it's still very important to be taken into account for understanding the influences dementia will have given the larger older adult community. We have 21 cities and towns, and there are some other rural parts of the county that are not yet recognized as cities. So that's something we are working, because again, we know in rural area it's very hard for research to engage and also see what's going on in there. So okay, because of all this disruptive demographic, and we need professionals that need to focus on improving older adults' quality of life. There are services in place like Ventura County Area Agency on Aging that are, but services remain limited for three main reasons. First, we have higher number of older adults, residents who need help, and they prefer to age in place. Then it's the lack of a sustainable plan for expanded home and community-based services for older adults, such as respite care, home aids, transportation. And then the number of professionals dedicated to serving the older adult community, such as gerontologists or geriatric social workers, are very limited. So we put together, based on all this information, we said, you know what, we need to put together a project that, even if we'll pilot it, but we need money for that. So in June 2018, administration of community living awarded us this amazing grant that allowed us to focus on people living with Alzheimer's disease and related dementias, and also on paid and unpaid caregivers. So that was exactly what we wanted. Now, let me tell you a little bit more about this amazing project. So our problem statement was like, we have a lot of people living at home with dementia. They don't have families. And then we know there is no cure, and without proper care, the disease most likely will increase at a higher speed. We also know that if there is treatment and pharmacological and non-pharmacological treatment, that will slow down the progression of dementia. We also know we have a complex task when it comes to family caregivers for dementia related diseases. And also we know that with intellectual disabilities, there is a higher chance for Down syndrome, like 50%, they will most likely develop a related dementia. So their caregivers also struggle, not only because they have to take care of their older process, but also taking care of somebody who cannot take care of themselves. So dementia is now a silent epidemic, and we need caregivers, but also we know we have a shortage of caregivers, and research doesn't show that most likely we're gonna have a sustainable task force for that. There is a lack of sustainable in-home long-term care programs. I mean, I think America did and does an amazing job when it comes to dementia, dementia awareness and creating environments where people will feel safe, respected. But we do have people who live by themselves battling dementia, and that will increase. And I think because my father passed away of dementia in Romania, I'm here by myself. I don't have kids. I take this, very personal, because that could be me in a few years, not that far from now. And it's scary. So I think one of my mission is to make sure that I'm doing something in creating that sustainable in-home long-term care programs for people who decide to age independently at home, in place, while having symptoms of dementia. Okay, so Ventura County Area Agencies on Aging are doing is doing an amazing job, but obviously there are gaps within their service. So, for instance, they cannot serve everybody because it's a waiting line, or maybe calls are not going through. So, there are insufficient resources and services for people living alone with ADRD. Resources are always scarce, and not only for ADRD individuals but also for those IDD with ADRD. And then I think we're doing great with caregivers, but there is a very interesting thing between caregivers and accessing resources. Who's going to stay with people they care for while they're going to take advantage of the resources existed in the community? Okay. So for that, we decided to, as our project objectives, like, let's see first who are the people living with ADHD in Ventura County and link them to the appropriate referrals, and having them taking advantage of our supportive services, specialized supportive services. We also wanted to identify those people with IDD that may have or may be at risk for developing ADRD. We also wanted to make sure that the behavioral symptoms management training and expert consultation is at easier reach for family caregivers. And we also wanted to, the overall idea was like, let's improve and enhance the quality of life and the effectiveness of whatever programs we have. We will try to make sure that the services we have, they do serve the purpose. Okay, in doing so, we needed to have a dementia capable system. And the dementia capable system stands that a community that can accommodate the needs of a population that experiences cognitive impairments. For that, we need a community that is aware about dementia diseases, causes, symptoms, treatments, prognosis, and also to create those safe environments where individuals with dementia will feel respected, will feel safe. And some services like that within the community could be dementia-friendly businesses or specialized services. In 2000, I'm not sure how many of you, probably most of you, are very aware about Dementia-Friendly America movement. It's something that started back in 2015, and in 2016, it started being very much talked here in America. So dementia-friendly Ventura County decided, like, okay, we need to become a dementia-friendly community. So they launched this. They become recognized by Dementia-Friendly America into June 2017. So that was like a pre-step for doing all of this. We had. So there were 3 core partners: Ventura County Area Agency on Aging, that was us; Alzheimer's Association California Central Coast Chapter. They were just giving support for caregivers and people with ADRD. And Independent Living Resources, Aging and Disability Center, they were giving support for individuals with IDD and their families. We had referring agencies, 14, and 4 agencies were our vendors. And we think about home care services, personal hygiene services like caregiving or respite care. Okay. Do I want to say something else in here? My timer, it's a little bit off. Okay. Okay, so now that I told you all about the background, let's get into the methodology. So we had 2 theoretical frameworks. One, it was the person-centered approach that we thought that doesn't matter. And this is something by now in America, everybody understands why it's important to be person-centered. But we also understand the self-direction approach, in which, yes, you may have some sort of limitations, but you're still in charge over your life, and you can choose what services you're gonna have. So you select, recruit, and retain. So that also allows the person getting care, and they will modify services based on their needs, because whatever happens this week, in a month from now, maybe maybe not be the same service they will need. Do I want to say something about the person-centered approach? No, it's too much information. Although I can come back and discuss more about it. So the proposed interventions, we were thinking like, okay, we have the dementia-capable case management. That must happen. In doing so, we will need to conduct person-centered care planning and make sure that we will have personal care services, provision of housekeeping services. We needed to make sure that we have counseling support network. In doing, our assessments were done on 2 levels: living alone, like ADL, IADL, nutrition risk, and also quality of life from the Alzheimer's disease. So it was the patient, not the caregiver. So we collected this every 6 months. We also proposed that dementia, we will provide dementia capable case management to individuals with ADD. So this was another agency that took over this intervention, and then providing caregivers with behavioral symptoms management tools. So we could refer for the other partners that were in the project, and they also could refer the different participants to our agency. So it was a collective effort in all of this. So our overall intent, it was to target those most at risk of falling through the cracks and being placed in a facility. Okay, so more details, because they are important. We got the grant in June 2018, and we started really doing groundwork on August 1st, 2019, and we had 3 years for this grant. We ended in September 2022. We had 348 individuals with ADRD and IDD and their caregivers. So altogether were ages 28 to 110. So ADD, ADRD 28 to 101, and also caregivers up to 110. So that was another interesting case, because you had older caregivers taking care of younger individuals with dementia. So that was a very interesting twist to find in the community. As I was saying, the service needs were done by referrals by other programs and community agencies that we had an understanding with them while doing this. The standard protocol in identifying our participants, it was the regular memory screening, and in here we had the Montreal Cognitive Assessment Tool and or short portable mental status questionnaire. And if the scores were elevated, we will refer the individuals to the primary care and make sure that there is a diagnosis for their dementia. And once that was done, we were assigning a social worker from our agency to just start making the referrals and understand the well-being and the psychosocial biopsychosocial component of our participant. The retention depended on the individual choice and desired or needed services, and the target population, again, we were interested in ADRD individuals that were living alone with a limited English speaking skills, ideally from LGBTQ older adults, because here in Ventura County, almost nobody is looking into that, and socially isolated and low-income individuals. My role, I haven't been with the agency since the genesis of this project, but I got I got on the team in October 2022, so right after the project was done. So I had to go back and trace everything. And I realized that as much as I would like to have a better understanding in terms of the results of the project, overall project, I had access only to Ventura County area agencies on aging participants. So I focused on only 276 people that were diagnosed with a form of dementia. So no caregivers. Okay, so what did I do and why is this important? So I wanted to see a little bit what's going on in terms of our demographics in the program. I looked at the activities of daily living and independent activities of daily living. I looked also at nutrition risk, and I did a group comparison bivariate analysis and multivariate analysis. So I really wanted to see in terms of the nutrition risk, the questions that they were assessing were like, do they always have money, like individuals, do they always have money to buy the needed food? If they eat alone most of the time, if they eat more than 2 daily servings of fruits, vegetable, meat products. Also, they were looking at how many drinks of beer, liquor, or wine they had almost every day, or if there were problems with their tooth or mouth problems that make eating harder. So I chose Spearman Row because I had a lot of ordinal data. And then I decided to go with the stepwise multiple regression because I needed to shift through independent variables, and this statistical test allowed me to add or remove potential explanatory variables in succession while testing for statistical significance after each iteration. So it was easier for me to see what's going on and have a better understanding, since this was treated as an exploratory research design. I had, as you can see, many variables because I wanted to see what is there, is there a statistical significant relationship between all these variables. All right. So what did I find? Well, I just highlighted with a red font what I thought that would be important for me. With my variables, for the ADLs and nutrition risk, I just recoded the data because I wanted to make sure that I can see between independent, moderate dependency and those who are dependent. And also it was interesting for me, you will see later, that we had the highest number of participants between 71 and 90. Most of them were white, and also at or below the federal poverty lane, 42%. And that in California last year for individuals will be $13,590. And that will be, I thought it was a little bit crazy because everything is so expensive over here, and I don't see how people can live on that budget. But that's why we need services like this. Most people were living alone. So 71 to 90%, 71 to 90 years old living alone and with dementia. Okay. My correlations, what exactly are they showing me? I do see a significant correlation, statistical significant correlation, and with positive and negative correlation. I use that one, as I said, to examine if any relationship exists between age, race, sex, sexual orientation, living status, marital status. And again, these variables were also very much requested by the agency. They wanted to see, like, okay, is there any sort of association that we need to know? And I was trying to tell them, just because there is an association is not a correlation, is not causation, but I'm going to look into that. So the older, what that association correlation showed me was that the older the age of the client, the higher the impact of marital status. And marital status for them, it was like high numbers divorced, widowed, or separated. I also noticed that most of participants in this data set were identified as white. White people will have a higher level, white older adult people will have a higher level of identifying and remaining identified as heterosexual, will have a higher level of reporting to live alone and being widowed or divorced. And they will always be at or below poverty line. Okay. Then I went even more into understanding the model of regression. And I highlighted a little bit just for those who probably have questions like, okay, let me know, is this all the assumption has been done correctly? And as you can see, I have my variance inflation factor and the tolerance all being within check, as well as Darwin-Watson. So that means the autocorrelation between the variables, there is a zero correlation, and multi-correlation between all the other variables are also non-existent. Okay. So what are those results mean? Well, it means that only 2 out of the 7 predictors or variables that I added to the model were significant predictors of living alone. Again, it's exploratory. I wasn't too happy, but it was better than nothing. So that told me that nutritional risk emerged as the strongest predictor of living alone, accounting not much, but still accounting for something when people are living alone. The second strongest factor was the time they spend in the program. So we saw that if they were spending more time in the program, they were doing better in terms of quality of life. So these results indicate that living alone, there is a higher chance for nutritional risk, and more time is needed for individuals to be in the program in order to have a better enhanced quality of life. All right, so discussions. Once again, the present work indicates that individuals with ADRD living alone need more time spent in the case manager, with the case manager, and there is a big need for individual supportive services on tasks related to ADHD, IADL in comparison to individuals not living alone. And we need to make sure that we are focusing on 75 to 94, 71 to 94 years old, sorry, my dyslexia, who live independently at home with ADRD, they show a higher risk for nutrition deficits. So what? These results really add to our understanding of the community support and the need for dementia specialized services for older adults that are living alone. And again, this will only increase older adults living alone with dementia in our communities. So I hope this project is just a starting point. We did have a lot of limitations, one of them being COVID. So when they started in 2019, everything was awesome. The case managers could go and do the assessments within the people's homes. And once COVID happened, we didn't want to stop. We wanted to continue, but everything had to be via phone. the concept of Zoom with older adults with different levels of dementia was very interesting, or and better to be avoided. My own limitation was that I had truncated data, and I could focus only the data that was included in this analysis, only 276 participants. So is there a lesson that I've learned or we learned as an organization moving forward? Because obviously we are still continuing working on this idea, and we hope to get more grants to support our work. So obviously we need community specialized services for people aging independently at home while living with dementia. We also need specialized trained people to coordinate these services. We need money to continue running the programs that we have piloted in here. We need better communication between agencies for data reports. But this is actually a dementia-capable system challenge, and that is due to the HIPAA agreements and doctor-patient confidentiality. So while thinking about this, I was wondering maybe what is the mandatory exception to confidentiality, and that is actually elder and dependent adult abuse. Maybe in here, further conversation with legislators can exist. What is abuse? Neglect and self-neglect, it's also a form of abuse. So maybe doctors usually have a tendency to notice only physical and sexual abuse, but there should be more to the part of the conversation. And maybe legislation could coin the regulations of HIPAA when ADRD diagnosis exists, and that will be more for the sake of coordination of care. Yeah. So now I'm gonna try to engage you a little bit in this conversation, and I want you to think about the community you live in, not where you work, but where you live. Is that community dementia capable and or dementia friendly? If yes, I would love to hear from you, telling me what you guys did, or what does it stand out as dementia capable for your community? And if not, what could be done in order to become a dementia capable, and how could you help? And we think now about community at large, not about those specialized facilities where you can have older adults. If you don't know, I added for you some questions that you may take with you if you don't want to answer now, while you are assessing the community you live in, if it qualifies or not as dementia capable. So for once, is your community, does your community have dementia friendly businesses? That's a very big one. Or maybe if you or your loved one is diagnosed with a form of dementia, would you have concerns or fears about going out in your community? I want to hear from you. I'm gonna stop sharing, and I hope I'm gonna hear from you. And I'm stopping sharing my screen just because I don't see you guys. All right. Anyone? So is your community dementia capable? No? Oh. Maybe I could look into chats.
I am starting to enable people's microphones, so if they would like to say something, they are more than welcome to.
Thank you so very much. Yes, I want to hear from my tribe.
Okay, everyone should be able to say something if they would like.
So the question was, is the community you live in dementia capable and or dementia friendly? If yes, share with us what you've observed in your community happening as dementia capable or dementia friendly. And if not, what could be done? And if you don't know if it's dementia capable, just think about do you have dementia friendly business that is recognized. If you or your loved one will decide, if your loved one that is diagnosed with dementia and goes in the community, will your loved one feel safe and respected? Do you have services, specialized services for dementia individuals diagnosed with dementia? Well, anyone? Should I call out? I don't want to put you on the spot, but maybe could I ask Katrina Trailer? Is the community you live in dementia capable? Katrina? No? Okay. Maybe Sarah? Wait.
I can speak for Lexington, Kentucky.
Yes, thank you so much.
So we presented earlier today, Christy Stanball and David Nisbet spoke on, Lexington, Kentucky, and it being dementia friendly designated. I'm on the committee, so I could tell you a little bit about, we are seeking out businesses, we are designating businesses, we are marketing to businesses, we are providing education to businesses. We've drawn up bylaws so that the expectations for education are being fulfilled. 100% of the management of those businesses, 50% of the employees of those businesses have to achieve the education, which is an online portal through the University of Kentucky. So it's web-based. So far, we have banks, we have attorneys' offices, we have elder law offices, we have beauty shops, we have restaurants. We're 3 years in and have a pretty robust group.
That is amazing. You guys are rock stars. We've done also the dementia friendly business training, and but nobody knows if the training was effective because nobody did assessment before and after. And based on the Dementia Friendly America movement, it said there is no clear-cut rule that you should assess. Ideally, it will be to assess, but they just wanted to make sure that the dementia awareness is out there. And that's what I'm working for my dissertation. I'm trying to, I have a hard time finding a validated scale to assess the community dementia business community. So I'm working on creating and validating such scale, and also I'm going to collect the data to see what exactly happened with that training. Was it effective? Is it effective? And also, how do we know people? Like for me, and maybe you can help me with that. This is a good conversation. So how do you know people who are working for that dementia-friendly business, they will be educated? Let's say they got to the business after you gave the training. Who's gonna give the training? Do they have to take it from the source, from you, or will they be secondary trained by their manager?
So we do in-person training with the managers, whoever needs to be involved initially. And then through the University of Kentucky, CE Central, we have a web-based training that they have to have their employees complete. So there's different modules associated with the training itself. And then we'll designate them once the training is achieved as a dementia-friendly business. And then we will revisit them every 3 years to ensure that they're keeping in compliance with their training requirements, 100% management, 50% employees.
Ah, that's it. So you do have a task force to go and check and for their, that's key. That's key.
Yeah, we have 3 separate committees. One is an education committee, so they define the education parameters. One is the business designation committee. So we seek out the businesses and we make sure that it's more holistic and not just lopsided to one industry. And then we also have a marketing group who does all the promotion. And then we have restaurant nights that are dementia friendly, for instance, with specific restaurants that are designated. We're having barber and beauty shop days for certain businesses that are designated. So, we market for them. And then oftentimes it's a fundraiser for the group itself because the proceeds go to our efforts.
I love it. You guys are so progressive. See, I'm learning something. I told you I don't know everything. And I put down your name. I think I'm going to connect with you and pick your brain a little bit more on that, because obviously you guys have done way much more than what we're doing, what we've done here. And probably you already know that it's such an intricate system that you have to go through in order to accomplish. So kudos to you guys. Yeah. Okay, now, do we have any questions? This is the Q&A. If you have questions, and we can have that conversation as Jamie started. If other people wants to share whatever they have to say about the presentation or about the idea of a dementia capable or dementia friendly community, this is the platform and the time when you can say whatever you feel like. Thank you, Jamie. That was amazing.
We do have a few comments in the chat that popped up while we were speaking.
Aha. Oh, Sarah. Okay. Okay, Jennifer. I would say that we think that we are dementia, but I still think we have. Yes, I think it's great that at least every community is starting thinking, and even if there is not yet a system in place, there is hope that it will be created. I think at this point the research community is starting paying more attention to it because more money are allocated towards this type of research. And we also understand that aging in place has been now researched a lot, and we know quality of life, it's better aging at home. And when we have dementia as a diagnosis, it's even more important to have people within a space that they know. So I think, yeah, doesn't matter when you start, as long as you try to give your best and start and do something toward accomplishing a goal, it's better than nothing. And I think sometimes even educating yourself or the community about dementia awareness, it's a big first step. Then Sarah said, yes, it's so important to have churches, because a lot of older adults find social support through churches. And that's why I always talk when, I am within a community of gerontologists. I'm like, they're my tribe. You can find your tribe through a church or through a platform and conference like this. We absolutely are social animals, and we need to be in touch with others like us. Aging services are amazing. Waiver, home delivery, yeah, that is extremely important. Okay. Hannah, enable micro, okay. Love that. Yeah, all great comments. We still have 10 minutes. If you want to add more to the conversation, I'm taking notes as you guys talk, because you have great ideas. Do you have any questions about the project that I presented? Cincinnati, Ohio, getting. Yes, museums, libraries, and churches are the most interested in education and engagement. And I think this is usually what happens with our leaders in the community. And then it will start the spillover effect towards others. Yeah. Yeah. I will stick around, guys, up to 1 o'clock if you want to say more, or it doesn't have to be about the project. It doesn't have to be about dementia unless you wanted to make it. If not, I think that's pretty much all about the presentation I had. Yeah. Thank you. Thank you so much for making time to be here today.
I have a question.
Yes, please.
I'm curious if public transportation would foster more dementia-friendly community service.
Yes. So we're trying to approach everybody, including the transportation system and the banks. And exactly as Jamie said, we're trying to go and educate everybody. It was hard for us, and when we had COVID, because we had to do it online through modules, and we don't really know how much attention people will pay through those modules, because they do have to take a quiz after, but it's online. So we all know how online can go. But yes, and I remember there is a very interesting case with that it happened here in Ventura County. One older woman had an appointment for her hair salon, and the hair salon was just across the street, but somehow she had one of her episodes and she forgot where she was. And one of my colleagues from Ventura County Area Agencies on Aging asked her, because saw her being confused, and she was like, I don't know where to go. I don't want to be late to my appointment, and I want to take a taxi, or, and she didn't know. And she was like, can you please, this is the phone, can you please call my son? She didn't know how to use the phone. So it was very interesting. And then the poor older woman gave the credit card to my colleague saying, here it is, you can have my money, just take me where I need to go. And that was a very interesting, like, we started thinking, what if another individual with malintention would have asked the older woman what's going on, would have taken advantage, like financial exploitation? Or what if the Uber or the cab driver isn't aware about dementia symptoms and don't know how to deal with that? So that's why it makes it even more aware to realize the complexity of dementia-friendly community. And I think many years ago, or when I think about Romania, because I was trying to do a research about Parkinson about last year over there, and I just realized I can't, because the only data I could get is not from Romania. It's from the European centralized data, which to me, it was a little bit crazy. But it's like the complexities you have to face, and you have to detangle all the relations that you have to have in order to create that community that will feel safe for the older adult, that people will understand and will have the education to help without any malintention, and to have the patience. And I think in with every generation there is a little bit more of an impatience that is happening. And I think when I think about Romania, because it's very much behind America in many ways, I sometimes think it's such an utopian vision to have, but because there are, like in America, we've made such progress, it gives me so much hope. Yes, it's not easy, but show me a change that has been easy throughout the history. So I'm very fortunate to work on this project and to work with promoting dementia-friendly community. So yeah, thank you, Jamie, for sharing your amazing advancements in this concept. Thank you, Hannah, for your question. Thank you, everybody who had the patience to stay with me till the end. And I hope I will connect with you. I my contact information, just in case if any of you are interested.
We have one more question in the chat.
Oh, what did I do? Stop. Okay. Chat. Okay. Maybe for Jamie. What are the most important training issues to be the focus in training business to serve ADRD client versus other senior citizens? That's a good question, Jamie. I think, would you like to answer that question, Jamie?
Yeah, so for us, we just, the education is about literacy in general, the perception that the individual with the diagnosis has. So for instance, beauty shops, music without words, not somebody sitting right next to you at the next booth. Remove the chair if possible, give space, maybe put separation in between the clients so that there's not distractions. The mirror can be a distraction. Turn them around, have them face the individual who's taking care of them. Restaurants, we thinned down the menu so there were only a few options to choose from versus the entire menu, which was overwhelming. Same with the music, same with the tables and the spacing of the seating. Of course, these were designated days and nights that we were able to create this environment that was dementia friendly. It wasn't as if it was incorporated into a routine business day, but these businesses were willing to do that so that their staff could be trained and they could be shown that it could be a productive opportunity for them. Not only that, but it provided them literacy so they begin to recognize the early onset disease diagnoses, type of habits that you could see, or similarities that you would see with clients who needed additional care. And they could recommend to families, your mom's had the same conversation with me 4 consecutive visits in a row. The family probably knows this, but they may not know the resources. So by providing the education, now the individuals are armed with resources, and potentially additional collateral could be given for the age-friendly initiative that's going on, and they could contact our group, and our group could help lead the discussion for next steps.
Yeah, that's very well spot on. We also have the logo for the dementia-friendly business that they can add in their window, and also we have for our clients of the agencies, we have kind of a business cards for caregivers and people with dementia, saying that I have dementia, please be patient with me. So they will put it when they will go to the restaurant. And also the caregivers will put that on the table saying, my mom has dementia, please be patient, and all that stuff. Also, it's important to educate restaurants, for instance, or other businesses to have very easy accessible signs, like big signs for restrooms. Also, it's important for caregivers to understand that a dementia-friendly business is not a respite care, so you cannot just go dump your parent there and just go do your things. It's very interesting. We are already done, but I want to share really fast, if I can, about my my contact information, in case if you guys have any interest in connecting with me. I will. Jamie, do you mind if I'll have your email address in the chat? No. Wow, that was a long one. Okay. So it's Elena Ionescu at ventura.org, CSULB.edu, or Ionescu at UH.edu. Any of these emails, you can reach me and we can connect. And who knows, maybe we will have an entire dementia-friendly community across America. There is a lot of work to be done, but it's exciting work and it's also doable. Thank you, guys. Thank you for your time and your amazing collaboration.
Yay! Thank you for joining us today. And I'd like to remind you all that we appreciate your feedback, and this session is eligible for continuing education credits. Please complete the evaluation for this session contained in the email you received this morning with the subject line OAC 2023 Post-Session Evaluation Link. And thank you so much. Thank you so much, Ms. Ionescu. We appreciate you and everything that you mentioned. I learned a lot. And fingers crossed for getting your doctorate. I know it'll happen.
It has to be. It has to happen. Okay, thank you so much. And now, would I just exit how does it go?
I'll end the session, and then